Hey everyone, my name is Ahmed Salman, and I am an endodontist practicing in Denver, Colorado. I would like to show you a case that I did when I was back in residency. I was at the University of Pacific. It was a very interesting case, but what we have right now is a footage for you to basically witness a root canal treatment from start to finish. And I think the footage we have can give you a better idea about what you can see um, from an endodontist standpoint and through a microscope. What you're going to witness in this video footage is not an exact replica of the treatment. I'm going to try to mention the things that has been cut just to make it a little bit more convenient and you don't have to sit through an hour or an hour and a half worth of procedure. So, give you a little bit of a history of this case. This is a case where a young lady presented for a hopeless and fractured tooth number 31. And then the opportunity presented itself where tooth number 32 can be act as a donor for auto transplantation versus a bridge or an implant. Taking a CBCT on those cases is very critical because it gave us the idea by looking at the anatomy, which was very identical. So what we ended up doing is we extracted the hopeless tooth number 31 and we extracted tooth number 32 and basically placed it as an auto transplant into the socket of tooth number 31 and splinted them with tooth number 30 and 29 with glass ionomer and glass fiber splint. The patient came back after 10 days to initiate root canal therapy. And what you're seeing right now is the first appointment. I did the root canal therapy in 2 appointments according to protocol. So what you're looking at right now is the tooth anesthetized, and then the patient is nice and comfortable, and then there is a primary isolation using a rubber dam. Sometimes there are some leaking areas or openings into the rubber dam. You can always seal those with a secondary isolation by using a paste or a caulking agent, by using Oroseal, or in this case, it's Opal Dam. So this is like a flowable composite where you can place around the areas that are open, and you can light cure them, and you're like nice and good to go. So we're going to go ahead and roll here. I'm going to tell you about my preference, what I use with burrs in starting an access opening. So at the beginning, I do use a tapered diamond, which you can use for a crown prep, for an axial prep or an interproximal prep. It has room that you can access mandibular molars with that has very limited opening and gives you a very conservative tip where you can see the outline. Now I'm looking at my mirror after a few millimeters of dentin, and just to make sure that my orientation is right and I don't need to correct it or go a little bit more mesial, a little bit more buccal, just to make sure that I'm on the right track. After that, when I'm cutting through that, I switch to a long shank round burr. So this used for surgical procedures. The nice thing about those is after you have some room, few millimeters into that tooth, you can actually insert by not blocking your vision, as you can see right now. So what I do with this is basically see where I'm going when I'm using my my burr. I want to see exactly where I am. So if you can see right here, I have a lot of room to see and look and observe. After cutting a few millimeters, I go with my Endo Explorer just to make sure that I have an opening into that pulp chamber roof, which right now I still don't. So then I just go ahead and proceed more with the burrs until I have an opening. So I make sure that I enter the pulp chamber roof at one point, and that gives me orientation. In this case, it's the mesiobuccal pulp horn. And then I go in and I predictably can extend that access to include all the pulp horns and make sure that I have a full access into that pulp chamber. Right now I'm extending to the distal and then buccal and lingual. And then after observing, I use an Endo Explorer to kind of see where the canal orifices are. Are they all exposed? And this is just necrotic tissue. The tooth is extracted. As you can see, it's white. There's no bleeding. And you can see some lip of dentin on that lingual surface of that tooth. So what I do in those cases, I use a diamond-coated ultrasonic tip that's an L shape. It's mainly for visibility to remove that lip of dentin and remove any unroofed pulp chamber. As you can see, I'm removing that lip of dentin with that. It gives you really nice visibility without blocking it with the head of a handpiece. You can do that with an Endo Z-burr, and that's very nice because it doesn't cut into the pulp chamber, so you can do it blindly just by orienting yourself about where is mesial and what is distal. Now, after you can see there's a lot of debris that's blocking the vision, so I go with sodium hypochlorite. and rinse everything out. That just dissolves the organic tissue and basically removes all the debris, and then you can have a better visibility afterwards. I always do this at the beginning just so I can see where the orifices are. So in this case, because we have a CBCT and we know we have a mesial root and a distal root with a single canal in both of them, but I always make sure there is not a second orifice that's meeting with that second mesial that might not be been overlooked with a CBCT. So in this case, the canal finding is not going to be an issue. So now after sectioning some of that irrigant out of the canal, I'm kind of like looking to see if there's a second mesial orifice, and then just inspecting that pulp chamber to make sure it's all exposed. I can identify where the canals are. Here I'm going back just because I see some of that overhang of that roof of the pulp chamber, just to make everything is nice and smooth. In this case, it's a very wide orifice on both distal and mesial. I usually try to orifice open by using a rotary instrument that only coronal flare. But in this case, they're wide open for me not to use that. So what I do is just basically looking at it, make sure there's no other anatomy that I need to visit. And under high magnification, you can see that it's nice and smooth. I'm just looking for any catch with an Endo Explorer, which there wasn't. So I can safely proceed with my hand files. I usually go with either an 8 or a 10 to just kind of check my working length. And I have an estimated working length from Radiograph, but then I use an apex locator just to verify that and then confirm it. Once I verify it with an apex locator, I make sure that I extend my glide path to a size 15. Size 15 file will give you a predictable and nice and smooth glide path for your rotaries to follow. This is a little bit of mineralized tissue that I just took out. And then we can proceed. Like I said, since we are, those are fairly wide canals, I don't use a coronal flare. I just go straight to my second instrument, which is in this case, it's a Vortex Blue 1506. Now the canals is open to a size 15, which is in hand files. It's a 1502. So this is basically just opening and enlarging the midroot section of the canals. It doesn't cut anything at the apex. It just creates a more open midroot section for my finisher file to go in without binding and having a lot of stress on it. I do a few bites and go out, inspect my file, make sure there's no stress on it or any unwinding, and go back again to the other one. And then as you can see here, it's sinking right in, and then that tells me that I reached my working length. And then I go out and inspect it, and then proceed with irrigation after that, go back with a 10 file and make sure that everything is nice and smooth. So irrigation, a lot of it, and then after that, it's ready for a finisher. The finisher in this case was a 2504, also Vortex Blue. So what a 2504 goes in and does, it just cuts at the apical third because coronal has already been prepped, middle has already been prepped. The only thing is the final shape of that apical few millimeters. Usually look at the file and see if I have any apical debris on the apical part of that file. If it's there, that means it cuts and then I'm done. If not, I go to a bigger size. Now final irrigation is done. I usually do a lot of this. This has been cut down for the purpose of video. So drying everything out and then using a sterile paper points in the canals, make sure everything is nice and dry. And we're going to put calcium hydroxide into that tooth. Protocol says you need extra antimicrobial activity, so we place calcium hydroxide for a few weeks, make sure everything is calmed down and prevent any possible resorption that might happen in a transplantation case. So now I'm making sure everything is nice and dry, and then we're going to proceed with calcium hydroxide. There's several ways of placing calcium hydroxide. The preferred way that I use is very helpful when you have a microscope. It's using a Navitip. Navitip, it comes in a syringeable calcium hydroxide. It's very thin, as you can see, and it has a stopper. So you measure it 1 millimeter short. As you can see, I'm placing it carefully under the microscope. And then you can see when it starts flowing back. So you don't push all the way and extrude out. And you can see the joint system by applying in one canal and the calcium hydroxide coming from the other. And then we're gonna put a sponge, which is I like it better than the cotton pellets. It flicks off easy when I re-enter the tooth. It doesn't get stick and get fuzzy into the temporary material. Followed that by Fuji 9. Now I'm placing Fuji 9 in there, and then after that, we just smooth it out, make sure it's out of occlusion. I like a wet cotton pellet just to kind of smooth everything out while it's still setting. And then we should be done after that. I'm taking that opal dam material, it just flicks right off before taking the rubber dam off. So this patient, after transplantation and waiting for 10 days, there was a periodontal abscess that developed, as you can see right here. So I know I cleaned and shaped, put calcium hydroxide, but I just want to ensure that everything is nice and clean at the time of obturation. So I'm doing an IND. This is a 15 blade. I just go to the fluctuant part all the way to bone, followed by some scraping and irrigation with sterile saline, just to make sure it's not flaring up or anything like that, and give it some sort of a drain or exit.